Okay, so now we are on cerebral aneurysm. And aneurysms may be saccular or berry aneurysm, ranging from a few millimeters to 20 to 30 millimeters in size, or fusiform atherosclerotic aneurysms. So, aneurysms, they can be secular or berry aneurysms. They can range from a few millimeters to 20 to 30 millimeters in size, or we can have fusiform atherosclerotic aneurysms. Other causes of SAH, and again, SAH is the abbreviation for subarachnoid hemorrhage, include trauma and illicit drug abuse, in particularly cocaine. The patient may have warning signs and symptoms if the ballooning artery applies pressure to brain tissue, or minor warning symptoms may result from leaking of an aneurysm before major rupture of that aneurysm occurs. In general, though, cerebral aneurysms are viewed as what we call the silent killer, and individuals do not have warning signs or symptoms of an aneurysm until rupture has occurred. And I really think this what happened to my ex-sister-in-law, and she was only in her 30s when this happened. And I know it was really hot outside that day, and they had been sitting out in the yard talking in pain. She might have had a couple beers or whatever, and she wasn't feeling well and got up and walked across the street. And instead of going into her apartment, she knocked on a neighbor's door, and when they opened the door, she just fell into the house, and that was it. And really, she died. And we thinking that she must have had some untreated hypertension, and that she ended up with a hemorrhagic stroke. And again, she was in her 30s when that happened. It's been a few years ago. I'm gonna say that happened in 2007, 2008. She had one son at the time that she died, and I want to say he might have been maybe 15 when she died. But it was really, really a tragedy, and really detrimental to the family. Other signs of this silent killer includes focal neurologic deficit, including cranial nerve deficit. They'll have nausea and vomiting, seizures, and a stiff neck like they do with meningitis. Complications of a oh boy, I got a tongue tie here. Aneurysmal, hope I'm saying that right. It's Aneurysmal, aneurysmal. Subarachnoid hemorrhage includes, meaning a subarachnoid hemorrhage secondary to a aneurysm, include a rebleeding before surgery, or other therapy is initiated. They'll have rebleeding before they can go to surgery, or as we said, any other therapy that they may initiate. And cerebral vasospasm can occur, and that's narrowing of the blood vessel, and any of that can result in actual cerebral infarction. And despite improvements in surgical techniques and management, many patients with subarachnoid hemorrhage, they do die. Some die almost immediately when a rupture occurs, and others die from subsequent bleeding. Survivors may be left with significant morbidity, including cognitive difficulty. So if they do survive, they do have a significant increase in comorbidities, including cognitive difficulties. Now, manifestations of a stroke. They are related to, I'm not sure if you can see the whole top of that slide. I'll try to make it a little better so you can see the very top. Clinical manifestations of the stroke. Neurologic manifestations do not significantly differ between ischemic and hemorrhagic stroke. An additional assessment question that you need to ask is the time of the onset of symptoms. This is important for all types of stroke and is especially important for ischemic strokes as it can affect treatment decisions. A stroke can have an effect on many blood functions, including motor activity, bladder and bowel elimination, intellectual function, spatial perceptual alterations, personality, affect, sensation, swallowing, and communication. So, these are manifestations related to right and left brain damage because they do differ somewhat. Because if you look at right brain damage, meaning they had a stroke on the right brain, all the changes going to occur on the left side. You will have hemiplegia, which is a paralyzed left side. You will have left-sided neglect. You'll end up with spatial perceptual deficits. The right side, on the right side, brain damage, it tends to deny or minimize the problem. The people that experience that tend to deny or minimize the problem. Rapid performance, short attention span occur in these people. They become impulsive, so you have issues with safety. They have impaired judgment, and they have impaired time concepts. Whereas when you have left brain damage, meaning the stroke occurred on the left side of the brain, it impairs everything on the right side. So usually deficit is opposite the side, so we would call that contralateral to the injury, which is opposite the side that the injury occurs on. So with the left-sided brain, you have a paralyzed right side. So you have right-sided hemiplegia with a left brain damage. You have impaired speech, language. You may even have aphasia. You have impaired right-left discrimination, slow performance. You're very cautious. You're aware of your deficits. You have depression and anxiety, and you have impaired comprehension related to language and math when you have issues on or have had left brain damage. Those are the things that it affects. Now, when you have talking about our clinical manifestations, still symptoms are caused by the destruction of motor neurons in the pyramidal pathway, and that's our pathway where nerve fibers from the brain pass through the spinal cord to the motor cells. And with these people, the most obvious effects of the stroke include impairment of mobility, respiratory function, swallowing and speech, gag reflex, and their self-care abilities. The characteristics of their motor defects include loss of skilled voluntary movement. They have akinesis or akinesia, impairment of integration of movement, alterations in muscle tone, alterations in reflexes. You'll have changes from hyporeflexia to hyperreflexia. And initially, depressed reflexes will progress to that hyperactive reflexes in most of these patients. So that's the changes from hyporeflexia to hyperreflexia. Now, because of the pyramidal pathway, because it crosses at the level of the medulla, a lesion on one side of the brain affects motor function on the opposite side of the body. Again, we call it contralateral. When the deficits occur opposite to the side of the injury. So, and they'll have an initial period of flaccidity. It may last from days to several weeks, and it is related to that nerve damage. And then we will have spasticity of muscles that follow that flaccid stage, and that is related to interruptions of the upper motor neuron influence. That aphasia that we mentioned, it occurs when the stroke damages the dominant hemisphere of the brain and it affects the language. They will have receptive, which is loss of comprehension, expression, which is loss of production of language, and global is total inability to communicate. Now remember, the left hemisphere is dominant for language skills in right-handed persons, and in most left-handed persons. Aphasia occurs when the stroke damages, again, the dominant hemisphere of the brain. And again, language disorders involve expressive and comprehension of written and spoken word. Now, when we're talking about the dysphagia, it refers to impaired ability to communicate. Most types of aphasia are a mix of non-fluent and fluent with both impairment in expression and understanding. A massive stroke can result in global aphasia, in which all communication and receptive function are actually lost. So you can see that dysphagia is sometimes used interchangeably with aphasia. And again, looking at if it's non-fluent or fluent. If it's non-fluent, minimal speech activity with slow speech occurs. And then when it's fluent, speech is present, but it contains little meaningful communication. So with these people, trying to straighten this up just a little bit more. Sorry. Get that whole thing in there. All right. So, as far as our clinical manifestations related to communication, dysarthria does not affect the meaning of communication or the comprehension of language, but it does affect the mechanics of speech. So these patients that experience the dysarthria, they have a disturbance in the actual muscular control of the speech. And those impairments may involve pronunciation, articulation, or phonation. And some patients can experience a combination of aphasia and dysarthria. So again, those are the areas that are impaired. Pronunciation, PAP, pronunciation, articulation, and phonation. As far as the patient's affect, patients may be frustrated, by mobility and communication problems. The patients who suffer a stroke may have difficulty controlling their emotions, and emotional responses can be exaggerated or unpredictable, and they are magnified by depression, changes in body image, and loss of function. As far as intellectual function, a left brain stroke is more likely to result in memory problems related to language. Patients with a left brain stroke often are very cautious in making judgments. The patient with a right brain stroke tends to be impulsive and to move quickly. An example of behavior in people with right brain stroke is that they try to rise quickly from a wheelchair without locking the wheels or raising the footrest. On the other hand, people with a left brain stroke will move slowly and cautiously from the wheelchair. Patients with either type of stroke may have difficulty making generalizations which interfere with their ability to learn. So, both memory and judgment may be impaired as a result of the stroke. And although impairments can occur with strokes affecting either side of the brain, some deficits are related to the hemisphere in which the stroke occurred. And we just said what happens on the left brain versus the right brain. Right brain people are more impulsive. They quick to move, won't lock the wheelchair or lift up the footrest, where the left brain stroke person moves slowly and cautiously. So, as far as spatial perception with these people, still wrapping up with the last of our clinical manifestations, this second to last. Our last one on clinical manifestations is going to be about elimination in these people. But spatial perceptual orientation can also occur in people with left brain stroke. Spatial perceptual problems can be divided into 4 categories. The first one is due to damage of the parietal lobe and causes the patient to have an incorrect perception of self and illness. In this particular situation, patients may deny their illnesses or not recognize their own body parts. The second category occurs when the patient neglects all input from the affected side, meaning they have an erroneous perception of self in relationship to space. This can be worsened by homonymous homonymousia. I used to know how to pronounce that. It is so funny, but you see the word listed right there under the unilateral neglect of the affected side. And when I was studying my CCRN tapes, the lady that I listened to, her name is Laura Gaspara. She is so funny, and to hear her say homonymousia, the way she said it sounds so funny, but she got a way of making that information stick in your head. So however you pronounce it, y'all can pronounce it better than I can. But anyway, that terminology means that they have blindness that occurs in the same half of the visual field of both eyes. The patient also has difficulty with spatial orientation, such as judging distance. The third spatial perception deficit is agnosia, which is the inability to recognize an object by sight, touch, or hearing. And then the fourth deficit is apraxia, which is the inability to carry out learned sequential movements on command. And because patients may or may not be aware of their spatial perceptual alterations. As care providers or as the healthcare team, we need to assess for this potential problem, as it will impact the rehabilitation and recovery of the patient. And then the last of our clinical manifestations is elimination. And elimination is talking about, with most of these problems, they have urinary and bowel elimination problems. They occur initially and are said to be temporary when a stroke affects one hemisphere of the brain. Prognosis for normal bladder function is actually pretty good. They actually listed as being excellent prognosis for normal bladder function. It says that initially the patient may experience frequency, urgency, and incontinence. They are frequently, although the motor control of the bowel is usually not a problem, the patients are frequently constipated. Constipation is associated with the immobility, weak abdominal muscles, dehydration, and diminished response to the defecation reflex. Urinary and bowel elimination problems may also be related to inability to verbalize the need to eliminate and difficulty with managing clothing, which actually results in them experiencing episodes of incontinence. Scheduled toileting and clothes that are easily removed may encourage independence. So again, you have occupational therapy. They may have to get stuff that have Velcro. I'm sorry about that. We may have to have clothing that includes the Velcro, so they can easily pull them apart and snap them. The same with their shoes and stuff. They have to have stuff with the Velcro on there. I'm sorry, some thing came up from my job talking about a supervisor's meeting today at 5:30 at Kindred. I gotta go to work there. I'm trying to finish this PowerPoint presentation so I can be totally done with these, and I can finish up with thank God for my clinical group with some of the clinical paperwork that was supposed to be a part of my teaching assistant. However, that person got laid off, and I'm just trying to go through and honestly grade the hard work that they have done. I don't want their work to be in vain, just like I don't want mine to be in vain, and some techniques or give comments that they can learn from. And I thank Miss Effie for picking up for these last couple weeks. I know she'll finish up this week, and like I say, once I got done with these PowerPoint presentations, I probably can be able to pick back up with my clinical group. But again, the elimination problems we just discussed, and I'm just going to move on to this next slide, and we are now moving into the diagnostic studies. Diagnostic studies, they do CTA, which is the CT angiography that provides visualization of cerebral blood vessels. It can provide an estimate of perfusion and detect filling defects in the cerebral arteries. You can have an MRA, that's magnetic resonance angiography, versus magnetic resonance imaging, which is the MRI. This is magnetic resonance angiography that can detect vascular lesions and blockages, similar to the CTA. Angiography can identify cervical and cerebral vascular occlusion, atherosclerotic plaques, and malformation of vessels. The intra-arterial digital subtraction angiography They call that the DSA, that reduces the dose of contrast material, uses smaller catheters, and shortens the length of the procedure compared with conventional angiography. Then they got the transcranial Doppler, abbreviated TCD, that is ultrasonography, which is a non-invasive study that measures the velocity of blood flow in the major cerebral arteries. Then next is the lumbar puncture. That can be done to look for evidence of red blood cells in the cerebrospinal fluid if a subarachnoid hemorrhage is suspected, but the CT does not show hemorrhage. And then the Lycox system, that was one of the systems that could be used when we was talking about increased intracranial pressure. That was one of the systems that they talked about using, which I was not familiar with. I'm just used to the ventriculostomy drain. But that Lycox system may be used as a diagnostic tool for evaluating the progression of the stroke. And then cardiac imaging is also recommended because many strokes are caused by blood clots from the heart. Okay, let's see what's next. Next is our interprofessional care, and our focus is on health promotion. Primary prevention is a priority for decreasing morbidity and mortality risk from stroke. The goals of stroke prevention include health promotion for a healthy lifestyle and management of the modifiable risk factors in order to prevent a stroke. And here we have those listed, those modifiable risk factors. And you know the non-modifiable, you can't change your age, you can't change your gender, you can't change your ethnicities. Those are the things that you cannot modify. But all of these you can do something about them. And patients with known risk factors such as diabetes, and you don't have to be a diabetic, hypertension, obesity, high serum lipids, or cardiac dysfunction, all of those patients will require close management. So again, that's a list of our modifiable risk factors when we're talking about health promotion, and that's the diet, weight control, exercise, smoking, alcohol consumption, blood pressure management, and routine health assessments. Now, when it comes to preventive drug therapy, common dose of aspirin is 81 to 325 milligrams per day. Other drugs that they use is Ticlit, Plavix, Prisantine, and then they got a drug called Agranox, which is a combination of Prisantine and aspirin, and the other name for Prisantine is dipyramide. And you know, they do Prisantine stress tests, you know, to tell the function of the heart. Pradaxa is one of the, talking about the anticoagulants, which is Coumadin. We are quite familiar with. They got the direct factor XA inhibitor, which is Xarelto, and Pradaxa, and then apixaban, which is Eliquis. Those are the newer group of anticoagulants. The primary advantage of the direct XA inhibitor factor in comparison to warfarin is that these drugs do not need close monitoring or dosage adjustments. And then as far as the statin drugs, the simvastatin, which is Zocor, or lovastatin, which is Mevacor, they have also been known to be effective in the prevention of stroke for individuals who have experienced a TIA in the past. And as you know, that TIA is related to atherosclerosis, And we had already mentioned that aspirin is the most frequently used antiplatelet agent, and the common dose is 81 to 325 milligrams per day. Surgical intervention. Evaluation must be done to confirm that the signs and symptoms of a TIA are not related to other brain lesions, such as a developing subdural hematoma or an increasing tumor mass. And the next couple of slides is going to show some figures related to a carotid endarterectomy, or putting a stent in, as it mentions that carotid endarterectomy, transluminal angioplasty, and stenting. So that transluminal angioplasty, that is the insertion of a balloon to open a stenosed artery in the brain and improve blood flow. The balloon is threaded up to the carotid artery via a catheter that is actually inserted in the femoral artery. So here is a illustration of what happens in that procedure. And let's see, that is located in your book on, let me see if I can find the actual page that's on. I see the brain stent, but I do not see the carotid stent. I'm sure this picture is in here somewhere. Well, let me go back some pages. I don't actually see this picture in the book. I'm going back to see if I'm overlooking it, because I just wanted to refer you to what page is on in the book. But I do not see a page that reflects on repair of carotid blockage. I really don't. Well, I'm gonna move on because I gotta go to Kindred, and I'm trying desperately to finish this PowerPoint, and it is already 5:40, and I gotta be there at 6:30. So with the carotid endarterectomy, they call it a CEA. In that process, the atheromatosis lesion is removed from the carotid artery to improve the blood flow. And it can, that carotid endarterectomy is performed to prevent impending cerebral infarction. So in example A, they show where the tube is inserted above and below the blockage to reroute the blood flow. In B, atherosclerotic plaque in the common carotid artery is removed. And C, once the artery is stitched closed, the tube itself can be removed, and a surgeon may also perform the technique without actually rerouting the blood flow. Now this next one, this is the actual picture that I saw in the book when it talks about the brain, and that illustration is actually on page 1354 in your text. It is figure 57-5, and it shows that the brain stent used to treat blockages is showing the brain stent that is used to treat blockages in cerebral blood flow. A is a balloon catheter is used to implant the stent into the artery of the brain. B, the balloon catheter is moved to the blockage area of the artery and then inflated, and the stent expands due to inflation of the balloon. And in C, it is showing that the balloon is deflated and withdrawn, leaving the stent permanently in place And that stent is what's holding the artery open, which in turn is improving the flow of blood. So that's what they do in the steps. They put the balloon in, they inflate the balloon, then they pull the catheter out, leaving the stent in place and leaving it inflated to keep the walls of that artery open in order to improve blood flow. Now, as far as the post-operative care, I'm not sure if I'm gonna make it through all of this, but I'm gonna try my best to do as much as I can, because I'm just halfway through these slides. I'm just on slide number 46 for real, and as I done told you more than one time, it's like 120 slides to this presentation for real. So I know they mentioned gerontologic considerations. I don't know if it's a slide on that, but you probably will talk. Well, you haven't had well, y'all have, I'm sorry. You've had your specialty in gerontology, so I'm not sure if you have already talked about that in gerontology, but let me move on and get some more done. So in the interprofessional care related to surgical therapy, post-op care is important. We're going to do our neurovascular assessment. We're going to manage the blood pressure, and we're going to assess for complication. And those are occlusion of the stent and any retroperitoneal hemorrhage. And we want to minimize complications at the insertion site. And we will minimize these complications at the insertion site by keeping the patient's legs straight for the prescribed amount of time. Our goals for interprofessional care is preserving life. How are we going to do that? We're going to do that by preventing any further brain damage and by reducing disability. And the time of onset of the symptoms is crucial information because it is a huge determining factor as to the type of treatment that the patient will receive. Acute care for ischemic stroke actually begins with our ABCs, airway, breathing, circulation. If you look at table 57-7, it will outline the emergency management of the patient with a stroke. Patients may have difficulty keeping an open and clear airway because of a decreased level of consciousness or decreased or absent gag and swallowing reflexes, oxygen administration, artificial airway insertion, intubation, and mechanical ventilation may be required. As far as our neurologic assessment, we definitely want to get a baseline assessment. Many of these patients worsen within the first 24 to 48 hours, so it's imperative that we get a baseline on these people. According to the American Heart Association, they recommend that acute care facilities have stroke teams in place. The stroke team generally consists of a registered nurse, a neurologist, a radiologist, and a radiology tech. The use of drugs to lower blood pressure is recommended only if the blood pressure is markedly increased, meaning it's got an arterial pressure greater than 130 millimeters of mercury, or a systolic pressure greater than 220 millimeters of mercury. In the case of an acute stroke, we want to give IV antihypertensive like metoprolol or Cardine. They are the preferred drugs of choice. And Cardine, that is a calcium channel blocker, and Lopressor is a beta blocker, but they are both antihypertensive medications. And although low blood pressure immediately following a stroke is uncommon, hypotension and hypovolemia should be corrected if it's present. before the time fly on these recordings. I'm already at 39 minutes already on this second recording. I'm going to, I think I'm going to stop this one, and I'm going to start the last one that I could do. And I might end up having to finish the very last one on tomorrow. So all of the ones that I get done tonight before I go to Kindred, I will upload the hyperlink, or when I go on break at Kindred, I will upload the hyperlink, and then I will finish it out on tomorrow. And I'm going to stop right here and come back to this particular slide and talk about fluid control and electrolyte balance.